Okay. Okay, thank you. Thank you, Professor Giaccas, for the introduction. I would like to thank the organizing committee for the kind invitation to participate to this very interesting congress, one of the most interesting congress related to the structural heart disease. These are my conflict of interest for this presentation, and we are going to begin with the definition. TAVI embolism is defined as the movement of the valve prosthesis after deployment such that loses contact with the annulus. Approximately, the incidence is around 1% and is associated with elevated post-procedural morbidity and mortality, and sometimes need a big number of cases for conversion to open heart surgery. TAVI embolism can occur towards the aortic or the ventricular direction and usually occurs during the peri-procedural period. However, there is also the delayed migration, approximately until 24 hours post-procedure. The main causes for this TAVI embolism for the balloon expanding valves is the high deployment undersized prosthesis, rapid pacing failure when this embolism is toward the aorta. For the self-expanding valves is the high deployment, the undersized also prosthesis, the post-dilatation error, and sometimes the disengagement of the prosthesis from the delivery system. When this embolism is toward the ventricular direction, for the self-expanding valves is the low deployment and the wrong annulus plane from the CT angiography. For the balloon expanding valves, the causes are the rapid pacing failure, the undersized prosthesis. This is the main cause for the balloon expanding valves, and the failure to pull the flex catheter off the balloon. In the early randomized TAVI trials, this embolization occurred at a rate of 0.5 to 1%, as we have already mentioned. In the latest randomized control trial for the balloon expanding valves is 0.2%, and for self-expanding valves is 1.2%. For more from data which are from more recent cohorts, the more recent cohort is from the German Center of Cardiovascular Research from Berlin, with 3,800 patients who have undergone TAVI from 2009 to 2021. 54 patients met the VAR criteria for TAVI embolism. In these 54 patients, there were not included cases with implantation of a second valve for the treatment of paravalvular leakage or after removal of the first valve due to coronary obstruction. The incidence in this cohort was 1.44%, and it was clustered in the beginning. It was 3.4 during 2009 until 2013, and 0.55% in 2020. 85% of this TAVI embolism occurred after implantation of a self-expanding valve, and 15% after a balloon expanding valve. The incidence of the embolism of the embolized valve after the self-expanding valve implantation was not changed significantly after introduction of the next generation devices. The mechanisms are the spontaneous embolization into the ascending aorta, the migration into the left ventricle, the accidental pullback of the TAVI valve into the ascending aorta during the removal of the delivery system due to incomplete release of the valve, the embolization during post-dilatation, and embolization due to loss of the capsule during the fast pacing period. The majority of the embolization, the majority of the embolized valves were into the aorta, the 41%, and for this 41%, the majority was in the aortic root. The risk factor from this cohort for TAVI embolism were horizontal aorta, the use of self-expanding valves, and patients with reduced ejection fraction. Also, there were frequent finding of some clinical leaflet thrombosis. Perhaps this is the cause of more frequent ischemic attacks in these patients, and also dissection and perforation through the snaring attempt. Now, when we have a balloon expanding valve which is embolized, when it is embolized in the aorta, the main reason is the interruption of the rapid pacing while the embolized valve into the left ventricle. It is because there was not sufficient anchoring of the valve, and during the post-dilatation, the valve was embolized in the left ventricle. How we are going to face this embolized valve, this embolization when it is in the aorta? We try to reposition it with inflating a balloon and trying to retract the valve in the descending thoracic aorta. When it is difficult to pass the aortic arch, it's better to pass another wire and try to crush just a little the valve using a balloon valvuloplasty, and after to retract the valve in the descending thoracic aorta. After, we try to pass a second valve from this valve, inside this valve. During repositioning of this embolized valve, the ventricular guide wire should always be maintained inside the valve so as to prevent the inversion of the valve and potential flow obstruction. Sometimes it's better to implant a covered or uncovered stent within the embolized valve, leaflets. In general, how to face a TAVI embolization when it is deep embolized, it is sure that it's going to require an open surgical repair. Sometimes implanting a second valve, it's better to trap the embolized valve if it is not so deep, it is in the left ventricular outflow tract. It would be better also for the surgeon. In contrast, the aortic embolization can be managed in the majority of time interventionally, with the surgery to be reserved for cases which are complicated with dissection or perforation. Usually, repositioning maneuvers using snares or inflated balloon can be used so as to deploy the embolized valve or to crush the embolized valve at an ectopic location. If it is complicated with coronary obstruction, it would be a medial proximal retraction of the valve, and care must be taken while manipulating the valve to avoid aortic injury, and especially with certain self-expanding valves which have a more prominent outflow portion. For example, the accurate Neo or accurate Neo 2. Here we can see in the picture C the result of a retraction of an accurate Neo 2, which resulted in a type B aortic dissection. So there are some anatomical predictors for self-expanding valve, which is the STJ height to be more than 24 millimeters, or there is an AL ratio, that means annulus perimeter to LVOT perimeter, to be less than 0.96. These are two predictors for embolization of self-expanding valves. That to say, a conical left ventricular outflow tract and tall aortic sinuses are strong anatomical predictors of ventricular embolization during self-expanding TAVI. But it is not clearly the bicuspid and the calcification. These are data from a cohort from Asian population. The data that we have are from the TAVI registry, which was published in European Heart Journal. It is for 30,000 patients from 26 international sites. There were 280 approximately embolized valves. The main reasons are heterogeneous. It was malpositioning, which led to valve embolization because of manipulation, of post-dilatation, of sizing errors, and fast rate pacing failures. There are also a lot of technical issues during implantation, but there was, from this TAVI registry, an independent predictor of embolization. This was the presence of the bicuspid aortic valve. Also, the use of self-expanding valves, lack of calcification of the native aortic valve, and inadequate identification of the landing zones. These are different technical issues. There is no time to mention all of them. Let's speak about the mortality rates. If the embolized valve goes to the aortic direction, then the mortality rate is 17% in 30 days and 30% in 1 year. If the embolized valve goes to the ventricular direction, the mortality rate in 30 days is 27%, and in 1 year approximately 40%. And this it is according to the treatment strategy. That's to say, the repositioning, the patients in whom there was a repositioned valve, the mortality rate was lower. In contrary, with the patients in which there was a conversion surgery, which the rate was 32% in 30 days and 45% in 1 year. Let's proceed with the conclusion. With the prevention, we propose that a meticulous pre-procedural planning in CT angiography with correct measurements, it would be the gold standard always. The selection of the most appropriate prosthesis type and size of the individual patient, accurate deployment techniques, assurance of the adequate temporary pacing, proper closed-loop communication between operators, assistant and technician. This is for the pacing, for the past pacing especially. An embolized TAVI in the ascending aorta should be pulled to an area where the lumen of the aorta equals the diameter of the TAVI outflow, and a stable position without obstruction of important aortic side branches is assured. Aggressive manipulation in general should be avoided because of the risk of aortic dissection, and the self-expanding valves usually require snares for repositioning, and embolized balloon expanding valves are mostly manipulated with balloons. The bailout strategies for the embolized valves are chosen immediately based on treatment urgency. When the valve is embolized into the left ventricle, removal of the device is mostly performed by open heart surgery. However, conservative management by advancing a balloon over the wire and pulling the TAVI valve outside the aorta has been accomplished sometimes. The majority of embolization occurs into the ascending aorta and can be managed percutaneously. And now I'm going to show you an embolized valve during a live demonstration 3 years ago. She was yes, she was a patient, a female patient with a mitral valve, with a metallic mitral valve. Πάμε ένα slide πίσω, σας παρακαλώ. Okay. This was in the beginning. The valve was embolized in the aortic root because of the delivery system.
The cone.
Yes, because of the cone, the delivery system. We tried to snare the valve, and after we implanted we implanted a second valve. We have changed also the wires. We used a Landerquist wire. Okay, thank you very much.
Thank you, George. Thank you for this wonderful, very didactic talk. Did you put any stent in the first valve or remain it as itself?
As it.
Okay. All right. Well, before passing the microphone to all of you, I would like to test our experience with a BEV, balloon expandable valve, embolization due to loss of capture of pacing, rapid pacing, and on grounds of very mild calcification of the valve. So we snared with a balloon. The valve, of course, embolized into the ascending aorta, subsequently to the aortic arch. And after that, we managed to snare the prosthetic valve and anchor it distally to the left subclavian artery level. We nailed it over there. After that, we put another very easy valve. And the patient is, I saw him 1 month ago, is 3 years and a half in a very good condition till now, without any problem. Well, did you have such a case, or if yes, how did you deal with any of you?
The main cause for balloon expanding valve embolization is the loss of capture.
Loss of capture.
Is the loss. And the main cause for balloon expanding valve...
Self-expandable.
Yes, no. The main cause of balloon expanding valve inside the left ventricle is the bad measurement during the CT angiograph.
CT angiograph. Yeah, there are too many mechanisms for that, but we will talk. Dr. Iacovo, if you want to say something.
Yes, Dr. Zakas. I think it was an excellent presentation. Congrats, George. I agree that after a certain period, this is something unavoidable. When you do more and more cases, you end up with a certain number of these cases. It's less than 1%. Now we have 0.3% in our practice. I think it's very important what you said on the meticulous study of the CT. But also a couple of things that I would like to point out. It's we should be generous when in doubt to pre-dilate, especially in the non-calcified valves, and also, as you said before, it's very important to pay special attention when we retrieve the nose cone of the self-expanding valves. This is where we have the problems. And I noticed in your case, which is really interesting, when we want to stabilize the self-expanding valve, which is embolized upstream, I think it's better to try to stabilize the valve with 2 snares as opposed to 1, because otherwise you risk the danger to distort the valve and also to damage the aorta. So I think this is something that we learned in the last few years. It's better to maybe you do one more. You have one more access, and then you place a second snare. You stabilize the valve, and it's easier and also more safe for the procedure and the patient to place second valve inside the other one. Okay. So overall, I think it's something that everyone who is doing this business to try to pay special attention now.
Yeah, statistics never lie, as usual. Well,
can I say something?
Yeah, of course. Dr. Katsimagklis, yes.
I want to share two cases of late migration that we had. One patient presented 1 month later, and when she was lying down, she complained of chest pain. And that because the valve moved upwards and was occluding the left main. The second patient was a 34 valve that was positioned low in the ventricle, but because the LVOT was small, there was no leak. 2 months later, the patient presented with gross heart failure. We did another CT, and we saw that the valve moved more into the ventricle, and there was a gross AR. So we put a second valve, self-expanding valve, a balloon expanding valve the second time, and resolved the issue.
Yeah, thank you. Well, as you said, that the bailout strategies are chosen based on these urgencies. Exactly. If you have a hemodynamic compromise, exactly. If you have an obstruction to the brain, to the heart, etc. Well, I understand that most of the cases were the embolization of the ascending aorta will be managed pretty good percutaneously. What about, and I want Dr. Patakos to say about that, to make a comment. What about when we have an embolization into the left ventricle? Then the things, it's not, Dr. Georgiou, if someone, I mean, is it safe? Is it a safe alternative to try to advance the wire, a balloon over the wire, and to pull up the THV to the ascending aorta? Is it a safe alternative, or send them to, for the beginning, to the surgeons to work out?
We've been involved.
Okay. We've been involved a couple of times in these unfortunate cases. What you are going to do with your wires and with your balloons would be up to you. We're there, and from the point that we're going to see the valve into the left ventricle, we're going to intervene. And our approach would be the routine. We'll go on bypass, and of course we'll try to take the valve through an aortotomy. Now, what the procedures before that, it's going to be up to you, to Kostas Parias, and all the associates.
Did you have anyone of such an experience with the embola? Oh. Yes.
Never lose your wire. As soon as you lose your wire, the balloon turns sideways, and they go into acute heart failure.
Yes, I have mentioned it. Yes,
so
never to lose.
The wire, you go and snare it through the balloon and turn it sideways. It's only 90 millimeters high, and it will come out. Those ends are like knives. The risk of aortic dissection is really high. Yeah. When you take out, say, you're right. The surgical is now going to be careful not to stab everyone. You can do it. The main thing is don't ever lose your wire.
Yes. I can be serious. If you lose your wire, you lose everything. Dr. Georgiou, this is.
So we do TAVIs for 14 years. We had such an experience with one balloon expandable valve. Maybe it was mainly because of the sizing issues. So there's a sizing issue. That's why it happened. It was a terrible experience. The valve was in the left ventricle. The patient was inoperable, as was discussed again with the surgeons in the cath lab. We keep the wire in the left within the valve. We try to pull the valve to the proper position, and unfortunately we managed to do that, but we had a razor of all the material which was still in the valve, and we had a massive stroke and the patient died a few days later. So I think the only solution is the surgical approach, and in such a cases where the patient is inoperable, we are in trouble.
Yeah, I think so.
Again, you're better off operating, but if you can't operate, there are ways to get it out. The main thing is don't lose your wire before you decide to do something. But then the valve starts to spin. As soon as it starts spinning, you go down a rabbit hole really fast.
Okay, you're right.
Thank you, George. Now,
Yes,
Dr. Pacharakis will continue with the next.
Yes, let's proceed. I'm very sorry for the delay. Thank you for the invitation. I would like to call Mr. Georgiou.